I'm happy to be here supporting this ECHO for primary care, and I will be focusing on youth suicide prevention. And even though it's a difficult topic, I think we have a lot of hopeful messages, a lot of practical approaches and tools that will be shared with you all today. So really looking forward to this presentation with you all, and definitely feel free to engage in the chat, ask questions. This is a topic that a lot of us didn't get a much formal training in early in our careers or in our training and practices. So really welcome questions now that we're starting to really make some progress in terms of best practices in this space. And I'd like to kind of have each one of you think about what your role is in this, and that it's not just individuals who are doing acute crisis care work that have a major role to play in suicide prevention. And we'll talk about actually the gaps of taking that kind of approach. So be talking today about adolescent suicide warning signs, screening and interpretation, and treatment. I'll kind of be providing a bit of an overview rather than going into major depth. I do have resources, and we have actual trainings that can go into depth on whether it's assessment approaches, safety planning, interventions, and things like that. But we won't dig into that. I do not have financial relationships or conflicts of interest to disclose, and I'd like to highlight what we're going to do in our time together. I will highlight some current trends in youth suicide, as well as key risk and protective factors. I do want to talk through the benefits of universal screening and the use of validated screening tools, assessment tools, safety planning approaches that can be routinely implemented in practice settings. And I want to say I do fully understand right off the bat that primary care settings have time restrictions, resource restrictions, and all of this. My wife is an integrated care psychologist. She works in a primary care setting, so I'm very familiar with the rapid pace of the work that needs to be done, the burdens that many folks face, and I would argue that there's always some room for suicide prevention and screening in a practice, and it's about finding the right fit and the right resources to make sure this can work in your setting, and developing a workflow that can accommodate these processes is something that we'll spend time talking through. But happy to have questions. I collaborate with some folks who are doing some great primary care work, and I am from the Center for Suicide Prevention and Research at Nationwide Children's Hospital. So we're always working within our hospital system to make sure we're meeting the needs of young people across the board. We're going to identify some of the best practices in risk assessment and safety planning, and then describing some ways to refer out and treatment options that we know work for youth at risk for suicide, and go from there. So as I mentioned before, suicide prevention can be an important but heavy topic. So do take care of yourself. If some of the topics can feel overwhelming, always prioritize your own self-care, and make sure that you are aware of the resources that exist for the community, and are available 24/7, including the 988 Suicide and Crisis line and the crisis text line at 741-741. So I'm going to kick right off with the idea that you play an important role in suicide prevention. Suicide's complex and multifactorial, meaning there's not a single cause or solution to this problem. We need a multi-pronged approach to prevention. We need to take a population health approach, and we need to take a best practice clinical approach to this work. So we'll be talking about different ways that makes sense. But we don't blame, just like we don't blame one person when an individual dies by suicide. We don't say there's one thing that solely caused it. We also know that the solutions have to be broadly applied and have to be focused on the data regarding effectiveness. We also want to have the common assumption that suicide is often an attempt to solve the problem of intense psychological pain and hopelessness. It's not a quote unquote, bid for attention, cry for help necessarily. It's a way of a person trying to resolve feelings of burden, hopelessness, feeling trapped psychologically and not feeling like they have the means to move forward because of overwhelming burden and pain in the context of accessing lethal means. So these are some of the things that we'll talk through. And then in many cases, suicide is preventable. We don't understand every nuance of this issue, but we do know that in the majority of cases, there has been an opportunity for prevention. This doesn't mean we're trying to make anyone feel guilty, because individuals who are at risk for suicide, especially young people, don't always tell or communicate to those closest to them what they're struggling with. So we really need the entire community to be part of this endeavor of suicide prevention. I'm just going to highlight this, that suicide is a death caused with injurious health with at least some intent to die. Suicide is only part of a suicidal behavior when at least part of the person wants to die. An attempt is when the person does not die, but they try to injure themselves and they did not end up dying. And then suicidal ideation is any thinking about, considering, or planning suicide. And then self-injury or non-suicidal self-injury is when a person harms themselves on purpose, and they may damage themselves, but they do not die because of it. And typically the reasons for doing that are different. It doesn't have, not for it to be self-injury, there's no intent to die. So there's just a couple of definitions. Words do matter when we talk about this. So I'll briefly highlight that how we talk about suicide to patients, to community members, to family members matters. So if we're communicating it in a hopeful and respectful way, we can make a big difference. So we no longer use terms like committed suicide, because people commit sins, they commit crimes, they, it's a sign of failure and stigma. We use objective language like they died by suicide, they lost their life to suicide. We don't say successful or unsuccessful attempt. Person, if they did not die, they survived a suicide attempt. We also, this is a little bit more in the gray area, but we also tend not to say completed suicide, they died by suicide. So trying to be objective and valuing the person's life and not demonizing suicide overall, given what we know is a fairly common experience in terms of thinking about suicide. We'll kind of talk about that. Even just generally, it's important to know a lot of what comes through our doors in primary care are mental health topics. We know that 11% of children aged 8 to 11 have had mental health challenges or severe impairment. 1 in 5 teens or more have had a mental illness with severe impairment in their life, and over 50%, and only 50% of youth with mental health conditions receive any behavioral health treatment at all. So we know that the front line is primary care. So what's walking in your door more often than not is a behavioral health condition or a comorbid or complicated presentation of a medical condition with a behavioral health condition. So we know this is going on, and unfortunately we haven't received as much training and support in this very important area. We also know that 50% of all lifetime mental illness starts by the age of 14, which is right in a pediatric primary care wheelhouse, and then 75% of all lifetime mental illness starts by 24. I will say in advance, we know this work needs to be done upstream. We're actually working on a grade 3 to 5 suicide prevention curriculum that's much different than a lot of what's out there, because we need it to be developmentally sensitive. We need it to engage young people, not to necessarily know all the stats and the details about suicide, but to know when I'm struggling, when my emotions become very intense, I know how to reach out to a trusted adult. I know that it's the right thing to do to work with other supportive adults to get to meet my needs and not to carry this burden alone. So in terms of young people and suicide, we also know that the trend has been an increasing trend since 2007. Also, incidentally, when the release of the iPhone was, and then shortly after that, iPads. But in terms of what we've been seeing is that there's been a 140% increase in female deaths by suicide in the past decade and a half, and then a 58% increase in male. So we've seen almost a 70% increase overall in the rates of deaths by suicide. And we also know that males are impacted much more than females in terms of deaths, even though females attempt suicide more frequently. Um, and then, so again, if you look at the overall national data, suicide is the second leading cause of death for youth and young people to age 10 to 24 in the US, only second to unintentional injury, which is motor vehicle accidents, unintentional drug overdoses, and many other accidents all lumped together in one category. So suicide actually becomes almost the leading designated single cause category out of this. And of course, many of the same risk factors that are responsible for drug overdose and other quote unquote deaths of despair overlap with suicide. So we've got some opportunity to address some of these root causes. And in each state, youth suicide is typically the second or third leading cause of death, so it doesn't vary too much by state. 1 in 3 young adults between the ages of 18 and 25 experience mental behavioral or mental health issues. So if we do this work early and upstream, we have a really good chance of reducing later burden in our healthcare systems and in our practices. So like most things, when you identify concerns early, yes, you're going to get more cases. You're going to have responsibilities to react and address these challenges, but the long-term benefits, both for the individual and the system, can be greatly reduced. I already kind of highlighted this, but what you'll see is there are disparities in terms of gender, or actually sex, in terms of males being more likely to die by suicide than females. It's maybe a little bit less of a discrepancy in the early years, but it really expands over time. And we know that the use of lethal means, including firearms, is a major reason for those discrepancies. And again, because females are attempting more often, but males are dying because their means are more lethal. Sometimes they're more impulsive as well. Okay. We could spend an entire hour just on this issue, but we know there are disparities in cultural considerations. This is just sort of one snapshot of a few different areas. We do know that indigenous peoples, Alaskan Natives, and American Indian individuals have by far the highest rate of deaths by suicide among any ethnic racial group. Suicide rate for Black children is age 5 to 11 is nearly doubled. Suicide attempts for Hispanic girls in high school is 40% higher than non-Hispanic white girls in the same age group. LGBTQ youth, including transgender individuals, is extremely high across the board. I would urge you to look at the work of the Trevor Project if you want to dig into that in a meaningful way. And then children of Asian American Pacific Islander descent are not as likely to experience mental health problems as the general population, but only half as likely to seek mental health services. So again, that's just a smattering of the cultural considerations that we look at. I'll put in the chat as we go along. In a recent open access book that we published, we have a number of chapters dedicated to understanding these topics that I'd urge you to read, and it would be at no cost because we made it open access. I want to look real briefly at the risk factors for suicide. So the strongest risk factors for suicide in youth really have been consistent for decades, even though the numbers have changed in terms of how many youth are impacted. But depression and mood disorders, such as bipolar disorder, are major contributors to later suicide risk. But it would not be true to say that a person who is at risk for suicide is certainly experiencing a mood disorder. And in fact, some of the more recent findings show us that if we're only looking for suicide risk in the context of a mood disorder, like a depression screener, then we are going to miss upwards of 30% of individuals who are at true risk for suicide. So let me state that differently. If we only screen for depression and then follow up on suicide risk, we are not going to adequately identify the number of youth who are at actual risk for suicide. So we'll talk about the importance of suicide-specific screeners rather than only giving something like the PHQ-9 and then following up with those who we think are highly depressed. alcohol use and drug use. So any disinhibitory substances are gonna interact with behavioral health conditions to increase risk considerably. And then previous suicide attempt. Those who have previously attempted suicide are much more likely to engage in later suicidal behavior. So we want to frequently be following up. We want to make sure there's a clear safety plan, even in the months and years afterwards. So that's really important. Other considerations, we talked about some of the sex differences. Family psychiatric history of suicide specifically seems to be heritable in families, but also those mood conditions, the experience of trauma, generational trauma, other environmental factors in the home can be considerations as well. Also, for those of you who are working with youth who have chronic health or pain issues, or even things like epilepsy, asthma, even some dermatological conditions, there are really these are things to pay attention to, as many are associated with later suicide risk. And there are environmental implications. Access to things that can be used to attempt suicide is a big deal. So lethal means access. That means firearms. That means medication, both over the counter and prescription. That means things that can be used to cut off oxygen, hang or suffocation is unfortunately an increasing way of dying by suicide, especially among younger kids. History of being bullied or being a bully are risk factors. Distress related to an LGBTQ plus identity. So it's not inherent upon someone who's lesbian, gay, bisexual, transgender to be inherently at risk for suicide, but if their environments are unsupportive or they don't have any resources to turn to, or they're in distress, that can increase risk. So having supportive adults or ways to express their identity actually shows reduced mental health and suicide risk. History of trauma. Sexual and physical abuse are major predictors of later suicidal behavior. So by doing abuse prevention, we're also doing suicide prevention. Knowing someone that's died by suicide can also increase the risk for anyone who's impacted. And then community violence and lack of psychological safety are contributors, especially among young children. Important to know that triggering events you can think of almost as the straw that breaks the camel's back. While a single event does not cause someone to attempt suicide, there are events that can be that push for a person who's been considering suicide, and that movement from ideation to action is what we're talking about here. And especially for young people, interpersonal conflict and loss. So it could be the death of a loved one, a breakup is important to consider. So we always reach in, we check in with kids after they've had one of these potential triggering events. It doesn't mean that most kids who experience this become suicidal, because it doesn't. But it does mean these are times when checking in is extra important because we know the risk is higher. Legal disciplinary problems. If a young person's been kicked out of school, if they've just been incarcerated or had some sort of juvenile justice interaction, rates can go up, and then being isolated from friends or losing a friend, to kind of talk through some of those. So we need to pay attention for warning signs, and we don't need to worry about if we're right or wrong in terms of whether there's true suicide risk or not. We pay attention to changes in behavior. We pay attention to what we're seeing on the surface, because adults, we know from lots of research, aren't particularly good at predicting a crisis or predicting suicide risk or the internal state of a child. So I do worry when we do a lot of work at schools from our center at Nationwide Children's Hospital in Columbus. We do lots of consultation, and we hear a lot of like, oh, our staff, we're pretty close with our kids. We can kind of tell when they're struggling or when they might be considering suicide. And the data would suggest that that's not accurate. Lots of kids have many reasons to mask this. So we want to ask directly these questions. And we also want to pay attention to these behavioral changes. So if we're seeing a behavioral change like the things listed here, wanting to be alone, decreased activities, giving away important belongings, risky or reckless behavior, self-injury, or an increase in energy following a period of depression, like they've come to terms with wanting to end their life, that would be a major indicator and a reason to respond. But we often don't have the luxury of seeing these things. So definitely respond if you see these things, but understand that we also need to ask direct questions, especially in primary care settings where we are a trusted adult. When you see a warning sign such as threatening to attempt suicide, obtaining a weapon, or seeking means to kill oneself, and that could be like researching online ways, or unfortunately, there's trends of ordering products that can facilitate suicide online. That's really problematic. We need to seek immediate help and look at a mental health evaluation and professional support. Talking or writing about why it ends one's life in school or on social media, it's really important to go through a screening and risk assessment and safety planning process if that happens. You wouldn't leave a child alone. You'd make sure the family is informed immediately and make a collaborative safety plan. The last thing I'll highlight here, again, this is its own talk, but we do know from lots of studies that adolescents who are exposed to suicide directly or indirectly are at increased risk for suicide. So imitative suicides, or some people call them copycat. I feel that's a little bit kind of downplays what this really is, but it is that young people are seeing a model of someone taking their own life. And they can, if they strongly identify with the person who died, they can see it as something that becomes more realistic and more functional. Luckily, there are barriers to ending one's life, and a person typically has some built-in protective factors, but those are broken down when you see a high-profile individual kill themselves, or they're watching a lot of content about death and suicide, and it becomes sort of those barriers or those reasons for living become eroded, and so that can be a challenge there. You saw that really with 13 Reasons Why, when there was a suicide that was graphically depicted. You've seen that with older or youth and young adults, with other famous individuals who die. There does seem to be a stronger celebrity effect with that. Okay, so before we transition to some of the more practical steps for working through suicide screening and risk assessment, I did want to take a pause here. We kind of went through some of the background, but wanted to give folks a chance to ask any questions sort of about the epidemiology of suicide, the reasons for it, the trends that we're seeing. Feel free to either unmute yourself. It's a fairly nice sized group, so feel free to unmute yourself or pop things in the chat. I'll give folks just a little bit more, and then I'll move forward. All right, I think I've given the allotted 7 seconds. Can pop anything in the chat, and I'll talk through some of our next steps. Okay, and just to highlight, I think some of the take homes from that initial part were suicide has multiple causes. There are some trends that we need to understand. We know that how suicide shows up differs by gender expression, by cultural factors, by sex, by access to lethal means, and by the values that a person has on their own life and what they're exposed to. So hopefully that gives you some things to explore. We do know that talking about suicide with young people is acceptable and feasible. Often it's the adults who have the most discomfort. It can be unsettling, so we need to practice it and kind of state it in a very direct way. The younger the child, the more concrete we need to be, and language is important. Like we need to say, you'll see in the screening steps, there's very clear language, not ambiguous. We don't want to dance around this topic. We want to say, have you ever thought of ending your life or killing yourself, and not have you ever thought about maybe hurting yourself, and using a lot of euphemisms, because that's not helpful with young kids. All right, so we talked a little bit about warning signs and triggering events, the types of things that help us detect when to move forward. And I will say I'm a much bigger fan of universal screening processes. Having screened within our school program, we've screened nearly 85,000 uh, youth from grades 5 to 12. And we know that you really can't just take either a parent's report or a teacher's report or even a behavioral presentation and assume you're going to identify um, almost all young people. You really do need an approach where you systematically screen. And it's important to know, even if you do systematically screen, that's probably an underrepresentation because some kids will still deny this. But if you ask them directly about whether they've had thoughts of ending their life or whether they've ever engaged in a suicide attempt, you will get a surprising number of yes responses. And those yes responses give you an opportunity to intervene upstream and really save years of suffering and initiate a process where a young person comes to terms with the fact that their brain sometimes tells them that they shouldn't be alive, that their brain is trying to convince them that their worth and their value is less than it truly is. So we have a lot of opportunity. The downside is it can be briefly stressful. The downside is you may have some parents that say, why are you doing this? Why are you asking these questions? I just came here for a medical appointment. And now you're asking these questions like, why would you have thoughts of killing yourself? Luckily, we have resources that explain and answer that question. We view it as a public health issue. We view it as a vital sign. In fact, our hospital calls it specifically. This is a pediatric vital sign. When you've got more kids dying from a particular cause than nearly any other cause, we actually don't have the luxury of ignoring it and saying it doesn't fit into our schedule. We need to find a way that we can support all young people and make sure that they're not dying of early causes, then they're not struggling for years and years and years. So that's definitely an approach we take. We view this process as taking the amount of time it needs to help this young person navigate the world safely. So the things I'll talk through would be screening, what to do with a positive screen, and then how to follow that up with the assessment. The good news is if there's a negative screen, that process that took you all of 60 to 90 seconds to initiate does not require follow-up. So again, the time it takes will only be commensurate with the risk that a child is facing. We've talked a little bit about warning signs. I'm going to just leave you with these resources and not go through these right now and get right to screening at this point. Why do we screen? We know that by asking all young kids directly about suicide, we can really make sure that we are reaching the kids who need it. For every suicide chief complaint, at least twice as many go undetected. And we don't want to invest our resources into preventable crises at a hospital level that's incredibly expensive and often traumatizing for a young person, especially when these can be addressed earlier. And we also want to screen to rule out those. We don't want to do a risk assessment for every child. We don't want to do a safety plan for every child. We want to make sure that we're saving the resources for those who need it. So using a good screener with good properties of identifying those who need it and not over-identifying is helpful. We can reduce some stigma by compassionate listening, by encouraging verbal and nonverbal, using encouraging responses. We do want to say, here's the point where I always suggest if we're going to do screening or we're going to ask a child if they've ever thought of suicide, we need to actually be willing to hear the answer yes. A lot of both young people and adults, because I've been on the receiving end of these types of sort of screening questions. If you're like, you're not thinking about killing yourself, are you? If you're not leaving room for a compassionate response of like, thank you for sharing that, it must be very hard. And I'm going to walk with you to make sure we get you the right resources in place moving forward. Then the honesty and self-reporting are going to be really low if you don't do that. So make sure it's not a checklist. You're not you're not checking a bunch of boxes here. You're hope, hopefully allowing someone to be vulnerable enough, sometimes for the first time in their life, to tell you something that they've possibly been hiding for a long time because of shame and stigma and lack of, and uncertainty about what will happen next, and fears that you're going to send them right to the hospital, which hopefully by the end of this training, you'll know that there are many alternatives to hospitalization when a person discloses suicide risk. Screening and limitations. There are limitations. Screening does not replace clinical judgment. It's people have reasons not to disclose, and so if you've got parents and other teachers or others saying yes, they said this, they did this, they're showing these warning signs, they told their friend that they wanted to kill themselves. The screening tool is not the be all and end all. So you typically, if a person is screening positive, and they're telling you they're having thoughts of suicide, you believe them. If they are, it doesn't mean you wouldn't follow up or clarify, which you do in a risk assessment, but you typically, a positive is a positive, but a negative could still be a positive based on other factors. Our goal is to reduce risk by identifying warning signs and inform the treatment plan. So we still need other information. It's not the be all and end all here. I'm going to share a specific validated screening tool called the Ask Suicide Screening Questions, developed by Lisa Horowitz and colleagues at the National Institute of Mental Health, but tested at many different children's hospitals, including our own, Nationwide Children's. And what this is it's a distilled set of questions, just 4 questions typically, and the 5th is asked if there's a positive, coming from much larger suicide screening questionnaires that have been validated in our gold standards. There was a goal to develop the most efficient screening tool possible that had really good properties. So we want to identify kids who are at true risk for suicide and reduce the chances that we're over-identifying. Also, what's nice about this is it's written at a 3rd grade level. So it's meant to be asked directly. It's concrete, no beating around the bush, and most kids can read this. Typically asked, there's a variety of ways that this can be delivered, whether it's a paper screener, tablet, and it can be administered by a wide variety of staff. But it can also be an in-person interview. And I would say with younger kids, especially those under 10, usually we are asking them directly. And it's, again, very, very straightforward. First couple questions about a person's thinking. In the past few weeks, have you wished you were dead? Yes or no? In the past few weeks, have you felt that you or your family would be better off if you were dead? Meaning, do you feel like a burden? Yes or no? In the past week, have you had thoughts of killing yourself? So this is about active ideation, active thinking about suicide, and then behavior. Have you ever tried to kill yourself? Yes or no? If yes, how and when? And then if any of those are yes, you would ask the imminency question. Are you having thoughts of killing yourself right now? So that gives you a way to gauge the again, the imminency of this situation and what you might need to do to establish safety in that moment. And so again, that's very quick. There's an NIMH toolkit, which has all sorts of resources. It has parent information guides that you can hand out. It's translated into 15 or 16 different languages. It's all free. It's all available. And again, it's very important to use a suicide specific tool and not only give this when there's been an elevated depression. If your workflow allows that, you might need to pilot it before launching into that. You want to have a workflow to make sure that if a youth is identified, they do get support. I would not introduce suicide screening if you do not have a way to follow up with young people. And so that should be something that you can do some quality improvement around and identify resources either locally or within the practice, or it could be with a local crisis provider. But we want to make sure that all kids who screen positive for suicide risk have a follow-up risk assessment and safety plan. And then also, it's important not to save this to the very end of a time with a patient, because you want to make sure that you can follow up if needed. And the more it's incorporated into the health record, the better. so that you can have the necessary prompts to follow up, and so that staff are aware that yes, if they have a positive screen, that is something that they can follow through on. Right. Any additional questions with screening before I move on to what you do if there's been a positive screen? And this would be on the risk assessment section. So a screening, remember, is getting a sense of who might be at risk. You've got a lot of kids, so for universal screening, we are looking for how to support those who might need a deeper dive into that. I kind of think about it. I sometimes use an example of when I'm looking at my kids' Halloween candy, they bring back a big, you know, big bowl of different varieties, and usually I'm screening for things that are orange, meaning Reese's cups, Kit Kats, and things like that. So I'm taking out of the whole group, I'm narrowing it down to a smaller group. Now, it doesn't mean just because it's orange that it's a Reese's cup. I need to further do an assessment of those positive screens to see if I can get that narrow example. So kind of a silly example, but hopefully that illustrates what we're doing. We're taking a large group, we're narrowing it down, and then of that group, we need to do a bit more of an inquiry. We need to learn more about is it the kind of suicide risk that requires an ongoing treatment specific to suicide? Does it require a collaborative safety plan that involves the family or community? So that's kind of what we're doing at next. And a positive screen, it's important to know, if you looked at that last section, one of the modifications that we have done in the past couple of years is there's one question, and I'll go back here and see if I can go backwards here. It's have you ever tried to kill yourself? So if a person had an attempt 3 years ago, it's always going to be positive, and therefore, hypothetically, you're always doing a suicide risk assessment, and that's not a good use of time. So we typically, after we've done a an assessment and there's no new behavior, so there's not a new suicide attempt and there's not new suicidal thinking since the last appointment. Once you've done that initial screen and that initial risk assessment, you wouldn't continue to do the same risk assessment over and over again. So we do want to manage resources effectively, and we do want to make sure we're talking about updated since last visit behavior. So just worth knowing. Also, I would highlight that when I'm talking about assessment, we have an entire 2 or 3 hour training that we could give that's a lot more detailed than what I'm going to talk through in the next 5 or 10 minutes. So understand that we're just hitting the high points here, but that really anyone can be trained in doing this suicide risk severity rating scale. It's something that we know that it's helpful to have broad training to make sure lots of our staff are skilled in this, and we can't always rely on the physicians or certain nurses to be able to do this work. It needs to be something that is distributed within our practice. And in terms of assessment, we have several key elements to any good suicide risk assessment, and that is our inquiry about the specific thoughts and behaviors. So we need to learn, what is the person actually thinking? Is it active suicidal thinking? Is it passive, where they feel like a burden and don't want to exist? Or would they take steps to end their life? Do they have access to lethal means? What's their intent? Do they have any intent to die? Do they have a strong intent to die? And then as you work through that and the past behavior, then you look at risk factors. So not all risk is created equal. So a person could have active thoughts of wanting to die, but they have lots of protective factors. They have lots of supports in place, and the risk factors are very small. That profile is going to look different than someone who has a lot of risk factors and very few protective factors, and they maybe can't plan for safety, and things are pretty risky. So we'll talk through that. And then ultimately, there is a clinical determination that occurs by the team to determine what the next steps are and can we maintain safety. So one example of a suicide risk assessment is the Columbia Suicide Rating Scale. It's pretty broadly used It's well known. It's got strong evidence base. It's flexible, and it reviews two major areas: suicide thinking or ideation, and behavior. So any sort of attempts or planning for suicide or preparatory steps. And then that helps really guide your next steps in terms of establishing safety. It's something that can be repeated for at-risk clients, and it's a structured but flexible tool. And it's standardized, so you can kind of your other team members will understand what you're talking about as you're using that. And again, we have a whole training to how to use the tool. It's freely available at the Columbia Lighthouse Project. I'm happy to also share documents. We use the very young child version because it's very concrete, easy to use. And it goes through suicidal ideation, meaning from starting from the sort of least, the lowest intent and lethality, which is wishes to be dead, then going to having active thoughts of wanting to die, but not having a method, to having a specific method, but not having an intent to act on that method, to then having thoughts with an intent to plan and a method, but without a specific detailed plan, and then the highest level of risk, which typically requires a higher level of care, is suicidal ideation with a specific plan and intent to act on that plan. And that's again, the highest risk. You actually see a pretty big jump when you've got at least some intent to act, and then an even bigger jump when there's a specific plan. So that's all. There's no level of suicidal ideation that we would not respond to and establish safety, but our level of response is dictated by that lethality and intent to act. And then suicidal behavior is also assessed. We assess previous suicide attempts, non-suicidal self-injury. When a person interrupts the suicide attempt, that's just as likely to predict later suicide as a previous suicide attempt. Preparatory action or exploring suicide means, and then how lethal it was, all predict later suicide risk. So those are our opportunities to learn. Our risk factors, which I'll go through quickly because we've really already covered these. You'd look at whether they're long-standing, unchangeable risk factors, and then more recent experiences that perhaps we have an opportunity with the family and the young person to modify. And again, there's a list there that you can look at, but I'm going to, in the interest of time, move forward here and highlight protective factors. These are things that you may very well have a chance to help modify and help reduce the risk of a young person's suicide by helping foster some of the things that are more modifiable, helping them develop more flexible thinking and coping skills, identifying reasons for living, whether it's babysitting a niece or their pet, or even looking forward to being a YouTube star, regardless of how realistic that is or how helpful it is. We're thinking about short-term ways of helping a person feel like life is worth living. So it doesn't have to be super realistic. It doesn't have to be something that we even agree with, but just is what can you use to get through now this immediate crisis state, which is usually going to be short-lived, to the next moment. What can deter you from taking action on those thoughts? And also keep in mind, it's not what we want, it's what the young person is going to use. We developed a web-based suicide prevention program for students, and a big factor that we considered is, if we're going to help them build coping plans, we need it to be coming from them, not us. So, sending them an after visit summary or writing a list of like, do this thing and give it to them, doesn't really work. That's not a collaborative safety plan. That's a list of resources, and usually they're crumpled up and thrown in the trash. It's got to be generated from the young person. It's got to be, what do they care about? What brings them value? What can distract them temporarily? That will work. Family and school support, bringing connectedness, bringing basically a sense of belonging to what they do, and social support is a big deal. Having some sense that I make a difference and I can have an impact on my environment is helpful. And a lot of our kids struggle with that. They feel like a burden. They don't feel like they have a lot of agency, and that can be an issue. Access to mental health care. We know that in rural areas, for example, limited access to care, um, even with telehealth can be tricky. So that access to mental health care can even be more scarce, which is problematic. But when you can find resources and strategies to get those to them, that can be life saving. And then reducing access to lethal means and can be is extremely helpful. So if any of you want more on that, there's a training called CALM. I believe the American Academy of Pediatrics has a specific youth version, pediatric version that I'd recommend. Again, counseling on access to lethal means or CALM training, and it's free. It's about a couple hours, and I'd highly recommend that as well. And that doesn't mean, again, violating anyone's constitutional rights. That means during a crisis, safely storing firearms, medication, and implements to use for hanging in particular. And you can do that while absolutely recognizing the rights of our families and making sure we do that in a professional way. There's a balancing act when we do all this. We put together all this information and we've got to make a determination. Can this young person be safe in the community with a number of resources? And understand that suicide risk is dynamic. It goes up and down like an EKG. It's not a static thing like, okay, for the next month you'll be low risk and next month you'll be high risk. In the same day, it can go up and down. So we got to have some humility about what we can and cannot predict. And that's why I'm often helping to empower young people and make sure they know that it's up to them to be part of this process. We're going to have to work together to better understand what makes you more at risk for suicide. What are the things that you can explore to keep yourself safe? And there's not 100% safety, goal. We can't keep a person in a bubble. We need to make sure that they are part of a process, the family's engaged, and we're working together to reduce risk as much as possible. All right, again, I want to give another opportunity here to provide any kind of feedback or thoughts that people have before we get into the final. I'll just cover intervention. What would you do? Should you have a positive risk? And go from there. Nothing else. Quiet group today. Feel free to kind of jump in there. Ask any burning questions that you might have had, or even thinking about any cases that you may have had that seemed difficult to manage, or you were unsure about their level of risk, how you might handle that. Okay, and again, feel free to use the chat. And in this, I'm going to really touch on the high points, so I can leave another 5 minutes at the end here. But want to touch on the idea that there's different levels of responses that you could engage in should there be a young person that you identify being at risk for suicide. And again, when there's high lethality, when there's imminent risk, and you really can't establish safety in the home or community, then you want to immediately implement safety precautions and explain that these are not punitive. You're not, the fact that they're experiencing a crisis is incredibly stressful to themselves, and that you want to provide the level of support, and keeping them alive is a priority so that they can live a meaningful and productive life and be at a point in the future when they can see reasons for living. And you would certainly want to make sure there's an emergency mental health evaluation. And that could be done if your practice doesn't have internal capacity. You could look at county crisis line, current other providers, mobile crisis, mental health evaluation center, emergency room, and other sources. So there are ways to approach that. The other sort of middle tier, moderate level of risk that's been established, you'd also want to take several steps. You'd engage in some collaborative safety planning, which we'll go through in a moment. You'll want to make sure that there's lethal means safety counseling, that you've provided some education, you've reviewed crisis resources, and you certainly would strongly consider a mental health follow-up so that they have a routine appointment in the future, and then certainly optimize treatment to support mental health considerations. And then if it's low risk, they've endorsed some level of suicidal thinking, but it's determined that risk is very low, then you provide some educational information. Um, you still might do some safety planning, but you're more reviewing crisis resources and considering a referral to a mental health provider as well. Assume that any endorsement of suicidal ideation is at least some level of distress and some signal that things are not as they are, um, going well for the person who's struggling. Uh, I'm gonna again just hit the very high points. This is an entire intervention process that can be understood, but collaborative safety planning, it's important for you at least to know some of the basics here. That if a person has uh, demonstrated risk for suicide, we know that by far the most effective approach to supporting next steps is collaborative safety planning. Suicide contracts, no suicide contracts are unhelpful. Having a person sign something that says they're not going to kill themselves is legally problematic and it's not helpful. Collaborative safety planning is when a person co-creates several strategies to decrease risk during a crisis. They understand what a crisis looks like for them, and they have layers of supports that they're going to use when they're experiencing a suicidal crisis. It improves outcomes. It works on instilling hope and actually creates some action steps for the client when they're struggling. Um, and again, it's not just about whether they say yes or no, but how they're conveying this acceptance and willingness to engage in the safety planning. So the safety planning content always involves warning signs, internal coping skills. So how do I manage this on my own? External coping skills. Who do I go to when I'm struggling? What are my trusted adults and crisis resources? What are my reasons for living? And how do I make sure that I don't have ways to act on suicidal thinking in a crisis? Um, and so, um, again, I'm going to go through just very quickly, highlighting that there are resources to help understand that each young person can identify ways to distract themselves. Keep in mind that during a crisis safety planning, we're just looking for a person to delay action on suicidal thinking. We don't need to fix them. These aren't necessarily long-term therapeutic solutions. They are opportunities to shift that negative thinking, realize that it's not definitive that they must die or definitive that their life has no value. We're looking to derail that thought and often provide some relaxation or self-soothing or distress tolerance. We're looking for a way to support them with others. Young people rarely kill themselves in the presence of others. Being with others is really important. It can be distracting, and it's typically more beneficial. Even if a person says, I want to be alone, I don't want people around me, it's still helpful to have people there with them who they can talk to, who they have trust. This may or may not be caregivers or parents. This may or may not be the counselors who we like to think of doing this work, but it needs to be a trusted adult who they can turn to for help. So, not necessarily another peer. There is room for peers for distraction and helpfulness, but we don't want to make that peer feel the burden to keep someone alive. That is also problematic. Lots of crisis lines. 988 is the easiest one. If you do nothing else but remember 988, that can get you very far. But understand there are some specific resources for different populations. Trevor Project is great for LGBTQ plus youth. And then the crisis text line for those who like to text are also available. Reasons for living is something you can always work with. So exploring what's one reason that you might be willing to stay alive for now? Future goals, thinking about what would be ultimately, you can't convince a person that they have to stay alive. So the idea is to delay action and say, well, you always have the chance to end your life down the road. What would you be willing to do to stay alive in the short term? What would be a reason why it might not be 100% the best option to end your life? And that may seem crass or a strange dialogue to have, but when a person's set on ending their life, it's really helpful to throw a seed of doubt in there. You're not likely to convince them that their suicidal thinking is wrong, and nor would you even want to try. You just want to help shift their thinking and give them opportunities to build on that. And again, reducing access. Most suicide attempts occur during a short-term crisis. Most suicide attempts are impulsive and happen within 5 to 20 minutes after that suicidal action. And most individuals who attempt suicide do not go on to die by suicide. So we need to delay action, and we need to restrict access to the things that are most likely to kill them, which is firearms in the United States. And that doesn't mean, again, they will never have access, or families need to do away with firearms. That's not realistic in many of our rural communities, but we can use gun locks, gun safes, storing in a neighbor's house, but we don't just store them up high or think that our young kids will not get into some simple lock. So I think I might be preaching to the choir there, but understanding we've got some options there. So, and I mentioned some of the safe storage things there. So I'm going to actually stop at this point and take any questions. I will highlight that there are some effective therapeutic strategies. Dialectical behavioral therapy is one of them. But even though we don't have a lot of studies showing a wide range of suicide-specific care models, there are a number that are promising. They almost always involve the family. They are skills-based, so they teach kids skills, and they do take a meaningful dose, so it's not usually super short-term. So things like DBT, CAMS, cognitive behavioral therapy, and a program called Safety A are things that have probably the most promise right now. So with that, I could talk another hour on schools, but we won't do that. I'll leave you with a few take homes, and then I'll provide some resources also in the chat. But yeah, so I know I did a little more talking than I usually do. Folks, please feel free to unmute and chat. That's what I'm here for. And hopefully this was helpful. All right, I can turn it back over if you're interested. I will leave my contact information here. Do feel free to reach out. Got plenty of options there. I'll put a couple of resources in the chat.
And I will send out the PowerPoint following this as well, so you'll have that in there.
Perfect. Sounds good.
Did you want to put anything in the chat?
Yeah, I think
Okay.
I'm going to do down here. Let's put our website.
Perfect.
And then I'll put, there's a free open access book that for folks who really want to dig into that. I ended that just a year and a half ago. And I don't have to declare conflict because I get nothing from it, but it was a labor of love. And actually it's been downloaded well over 100,000 times,
wow.
which is what we were trying to do is really get people access to this work, which is written. It's actually, and I will highlight in advance, even though it's a Springer text, it's on youth suicide. I made sure all the authors, these are like world-renowned experts. I told them you have to write for like a traditional audience. Like, don't write a big academic thing, right? Write for advocates, lawmakers, clinicians, providers, and tell us what we need to know. So hopefully that is helpful as well. And then I'll throw a couple other links in there. But yeah, thanks so much for having me.
Yeah, thanks so much. Great presentation and information.
Thank you.
And I'll just leave this open for just a couple minutes. Then if people are wanting to access those resources.
Right. Oh, I'll throw on the NIMH website too that talks specifically about screening. That's really helpful.